Okay, Chris.
Second part of pervasive nature of stealth pathogens. Part 3 will be this afternoon, right?
Yep, 1:30.
We have more didactic today, and I highly encourage you to see the picture this afternoon at 1:30. Maybe you don't want to fill up too much on lunch. Take an antiemetic before you come in.
Chris, are we going to be able to have a VCR of sorts this afternoon?
Yeah.
Good. Okay. Well, thank you. Oh, not yet. Thank you very much. This is a three-part talk for your benefit and for mine to help me get my material together a little better, and also to spread out the dosing of this a bit. I was speaking in very broad strokes yesterday, and the idea is to give you the overview as to what much of this is about. I very strongly recommend that if you found this book out in front, that you buy a copy. You'll be able to find much more specifics about some of the things of which I'm going to speak in this. Now, one of the areas that we're getting into today has to do with stealth viruses. And this is quite a new concept, and it's somewhat out of Dr. Mattman's field. In that regard, I'd have to refer you to the work of Dr. John Martin. I've got many of his articles available, and much of his stuff is also out on the internet. If you were to look up stealth viruses or John Martin or some combination thereof, you'd probably be able to get a hit on many of them. Something else I should do, and it's done with a little bit of peril, is I'm going to give my personal email address. If you're interested in these types of things, you've got specific applications, and you'd like to take this further, you want now the commas and the semicolons and the dotted I's and the crossed T's and all that. My email address is quite a simple one. It's Philip Hoekstra, PhilipHoekstra @hotmail.com. And I'm pretty good about answering my email. It's actually easier to contact me that way than by phone or by fax. Now, yesterday when I was done, there were a couple of questions that I thought were good enough for me to address here before getting into the material once again. There has been a lot of material talked about in the circles of holistic and alternative medicine regarding pleomorphic organisms. And the question came as, what is the difference between a pleomorphic organism and a cell wall deficient organism? The best answer to that is that much of the understanding of pleomorphic organisms, pleomorphic of course meaning or meaning multiple bodies, was really part of the steps necessary to where we are now with the understanding of cell wall deficiency. So when we're talking about some of the stuff that Gruner did so many years ago and called his organism Stepanospora polymorpha, or when we're talking about Virginia Livingston and the progenitor Cryptocytes, or we're talking about Endoline with his endobion and protid and that type of thing, or we're talking about nasons with the somatid. These were basically all observations done with a very limited understanding. And when you start to piece these things together, you begin to go to a greater level of understanding. You see the bigger picture. If you are working around some of these more limited technologies, it would behoove you to go to the top of the mountain and to look at this more comprehensively. Because in many ways you're making embarrassing mistakes. I certainly was for many years when I was a good devotee of Livingstonism. I was a good disciple who basically followed the protocols and the techniques and didn't do a lot of questioning until I began to find some cracks in the wall. And at that point, I began to do some original investigation, and much of what I was working with became the house of cards that fell down. And it was a very disillusioning experience. So one of the axioms of life is never to be a good disciple, but to do original thinking for yourself and verify these things, especially when you have the responsibility of working with patients who are counting on you. If you're pervading things upon them that are, well, we'll use the term fallacious, even if unintended, you're not doing them any type of service at all. You can lead to a lot of erroneous conclusions, get them going on many types of treatment programs that are misdirected or ineffective. Now, in that same context, there are products that have been developed around the notions of the pleomorphism. And to tell you the truth, I have no idea whether Nason 714X actually works or not. I've heard anecdotal evidence that's quite conflicting in some regards. I've heard miraculous tales from the practitioner himself who was giving 714X to an advanced AIDS patient who said that the patient was now seronegative and no longer had AIDS in any discernible way. That's pretty miraculous. On the other hand, I speak to practitioners who tell me that they've used 714X in conditions that they didn't think were all that challenging, where the patient was not in very serious shape and apparently had no beneficial effect at all. Similarly, there's been a line of products developed by the Sanum people around much of the endolynism, but this has been done very anecdotally. It's been done not really dependent on the correctness of the science of endoline, which is very fortunate. And I have heard generally good things about the Sanum products. The Sanum products have shown a great deal of benefit dealing with a broad variety of conditions. So pleomorphism, which has become something of a buzzword, is really just a transitional state to what we understand now for cell wall deficiency. And it's kind of curious that for many years, people studying microbiology have avoided bacteriology as an area because they had the mistaken belief that everything important was already done, and that they chose to concentrate on virology and push their careers in that with the notion that they could they'd have a better chance of major achievements and lots of funding. Bacteriology still has a lot of unexplored areas, and again, much of the stuff that we're talking about here is from the X-files of bacteriology. And I think when you see the list of some of the various disease states that I'm going to have and the evidence that there is associating them with various types of cell wall deficient organisms, I think you're going to see a need for this type of thing. Now, the first thing I want to talk about is the notion of the stealth virus. And again, the word stealth does have a definition. It basically means a disease state, a tissue-destructive disease state without any corresponding inflammation. And this is something that does not fit in the typical medical microbiology model. Usually it's the immune system then that is responsible for evoking much of, I should say the inflammatory state that's responsible for evoking much of the immune response. And that's not taking place in these. Now, beginning in the 80s, Dr. John Martin isolated a previously unknown virus from patients with a common syndrome. These patients all had several months of acute illness that involved severe headaches, diffuse muscle pain, diarrhea, and often resulted in a long-term chronic fatigue syndrome of 5 to 7 years. Now, Dr. Martin had tools available to him that people like Endoline and Nasons and people like Glover never had. He had the ability to do polymerase chain reaction as well as DNA sequencing as well as DNA hybridization. And a point I wanted to make yesterday was that it's knowledge of the genetic material that defines the organism. It is not on how they appear or on some of their metabolic properties. What he found was something very much unexpected. He was expecting perhaps to run into some new type of virus, but he didn't have a notion as to just how new this was. What he found by studying the genetic material was that first off, this was a DNA virus, which makes life a lot simpler when you're a virologist because you don't have to work with reverse transcriptase. And he found it was a relatively small virus. It was about 80,000 base pairs. But what he found was there was a very high degree of confidence for a relationship between this virus being derived from the simian cytomegalovirus. Now, the simian cytomegalovirus is actually a very common contaminant that shows up in tissue cultures. Something in the neighborhood of 63% of all the tissue cultures, no matter in what context they're being used, even under the best of circumstances, contain simian cytomegalovirus. The source of this is probably the green monkey, and you've heard of the tale of HIV in the green monkey. But the simian cytomegalovirus has something in the neighborhood of 300,000 base pairs to it. So it seems very odd that this would have so much in common with the CMV and still be related to it. And what he discovered was that this was more of a fraction. This was a essential package taken from the simian cytomegalovirus. It was not some type of analog from it. But as the numbers of these base pairs were reduced, what also occurred is not only did we have a stable virus that was capable of replicating in cells, but also by shedding many of these other base pairs, it had also shed the characteristics that give that cell its antigenic characterization. Much of the recognition of the immune system for the genetic material of the simian cytomegalovirus, as well as the cell wall, or I should say the cell membrane proteins that were showing up on the simian cytomegalovirus infected cells, were not there. So in patients who died of this particular syndrome, he found that the principal site of pathology was the brain. And in studying the brain, he found some very unusual things. He found foamy destruction of brain tissue with no inflammation. And he also no circulating antibodies against this particular virus. So he actually borrowed the term, I guess, stealth virus to describe this because it was capable of causing infection without evoking an immune response or causing local inflammation. Now, he began, once he had a tool by which he could identify this virus, he began to study it for its pervasive nature, and he found some very interesting things. One of the things that he found was that this virus was showing up very frequently in cases of autism, and it was also showing up in Rett syndrome and also in chronic fatigue syndrome. Now, that's not to say that this particular virus is the causative agent, but it certainly is very interesting because there does seem to be a profound neuropathy associated with each of these conditions. And no particular antibodies as well. But having the polymerase chain reaction testing available to him, he was able to detect the virus circulating in these people's blood every time. Now, this is a major public health issue because the most common use for the or most common source for the green monkey tissue cultures comes from the live polio vaccination. And because you're dealing with pooled vaccines or pooled cell cultures with the live polio vaccination, a great number of people have been exposed to this simian cytomegalovirus. And there's a very compelling link between exposure to this virus from the live polio vaccination and the incidence of autism, Rett syndrome, and chronic fatigue. In kids, this may show up fairly quickly in terms of autism, but it may take many years for it to show up in terms of chronic fatigue syndrome. Now, as he was studying this, he noticed that while he was working with a stealth version of the simian cytomegalovirus, this became a common mechanism. This getting down to an essential package, an abbreviated version of some other virus that didn't allow for antigenic characterization any longer. And he found the stealth version, this non-inflammatory version that was still stable and tissue destructive of herpes simplex, the Epstein-Barr virus, and human herpes number 6. If you are keeping track of human herpes viruses these days, we're up to at least 8, and there's more to be discovered out of that. It's kind of interesting that human herpes had its origins in terms of discovery as an accident that happened relatively locally. It was an observation of a cluster of chronic fatigue syndrome occurring in Incline Village, Nevada, that helped to identify human herpes 6. And one of the contexts I'm going to be talking about human herpes 6 a little more is in its association with AIDS. Human herpes 6 seems to be a sine qua non for the development of AIDS. Now, this notion of stealth bacteria and the stealth viruses has very powerful implications, as I promised you, for a great number of disease states. And the context that really interests me in that type of thing are the so-called autoimmune conditions. Now, in this respect, Dr. Mattman had done some work, and there's certainly been work by a lot of other people as well, but Dr. Mattman's been a very powerful influence to me in studying this. But I was still looking at it in terms of bits and pieces, that there was a cell wall deficient bacteria associated with this disease or that disease. But one night I had a dream, and to paraphrase King, and this dream was not all about peace and harmony. This dream was actually about a raccoon hunt taking place in the swamps of the southern U.S. And in my dream, I had an omniscient view of a wooded swamp. And in this dream, I saw hunters with torches. I heard the baying of the hound dogs. And somewhere or another, the most obscure thing in this whole picture was the raccoon. And as the raccoon is racing through the swamp, these baying hound dogs were chasing it down, knocking down some of the vegetation. And the hunters with their torches, as they're chasing after the hound dogs, are setting fire to the swamp. And as I began to put that in the context of thinking about autoimmune diseases, I thought that the most obscure thing in these autoimmune diseases is the notion of a causative agent. And I began to see the baying hound dogs as being antibodies. And I began to see the hunters with their torches as being cytotoxic T cells and natural killer cells. And I saw the swamp as being the terrain or the environment of the patient. And this is much the case for many of the so-called autoimmune diseases, where you see much of the effect of the disease being caused by the immune system. And it's very, very difficult and not easy to indicate some type of microorganism out of this. The context in which I began to study this with Dr. Mattman some time ago was in multiple sclerosis. And here we had fortuitous timing because much of Bergdorf's work on Lyme's, which was really some excellent microbiology, gave us new culturing techniques by which we could grow and culture Borrelia organisms. Now, the spirochetal organisms generally are a real pain to work with. They require absolutely superb conditions. And as of yet, there are very few people who can successfully grow Treponema pallidum, the causative organism for syphilis. So if you're being really strict about it, you can't even satisfy Koch's postulates for syphilis, and Treponema pallidum is a related organism. So again, Bergdorf deserves a good deal of praise for the excellent work in microbiology that allowed us to connect the Borrelia burgdorferi with Lyme's disease. And in the process of doing so, he gave us new techniques to grow spirochetal organisms. And we were able to pick up on work that had its origins back in the early part of the 1900s from a German investigator by the name of Gabriel Steiner. Gabriel Steiner had a very frustrating experience of being able to identify a small bacteria, what he described as a micrococcus, in the cerebral spinal fluid of multiple sclerosis patients. But he found no particular agent that would allow the death of the organism without necessarily causing the death of the host. So treatment then seemed pretty obscure. Now, really by using excellent culturing technique, he was able to grow this out to a spirochetal organism. And what he discovered was the typical form that he was finding it in circulation was pleomorphic, something that we can describe now as being cell wall deficient. But he died a very frustrated man because he wasn't able to take this any further. And other people trying to duplicate his work had very limited amount of success. The various multiple sclerosis foundations had funded this type of work and basically came up dry in every count. And Dr. Mattman chose to pick up this line of work now with the improved tools of being able to culture Borrelia organisms. And we began the very painstaking process of culturing people's cerebral spinal fluid. And it's often very difficult to ask a patient for a sample of cerebral spinal fluid because it produces some pretty powerful headaches from even a couple cc's. And when you can't necessarily tell them that you have a direct benefit for them and they're just kind of horsing around with this type of thing, you either have to take some very good salesmanship or a very gullible or desperate patient. But we did obtain samples of cerebral spinal fluid from a number of MS patients. And Dr. Mattman was able to get growth. And as I mentioned yesterday, something a testament to her patience and really excellent skill as a laboratorian. She was growing this stuff consistently. And she subcultured it and subcultured it and subcultured it for 9 months before it decided to revert into an organism that we could recognize as probably being one of the Borrelia. Now, we have done culturing, and much of the culturing type of tests that we've been working on for Borrelia are largely being eclipsed as antibody tests, fluorescent antibody tests of a similar type to what Dr. Whitaker's developed for Lyme's disease are likely to be coming down the line. And for many years, there's been anecdotal evidence that taking antibiotics, especially some of the tetracyclines, seem to have a beneficial effect for many multiple sclerosis patients. Now, the next step in the process was attempting to do sensitivities now that we had successfully worked up a way of doing culturing. Whereas initially, while we were fumbling around in the dark, it literally took 9 months to get a successful reversion. Now Dr. Mattman is able to reliably get that in a matter of days, again by finding what kinds of condition the organism likes. Now, we've been able to show that the organism is a spirochete, and we've believed that it is of the Borrelia genus, but that is of yet unknown. So as best right now we're calling it the same thing that Gabriel Steiner did from back in 1918. We're calling it Spirocheta myelophora, which means this stuff particularly loves the myelin sheath of nerves. Now, we've been able to, as the culturing technique is improved, we've been able to find this organism consistently taking place in the blood and the urine of the multiple sclerosis patients that we've been dealing with. As far as I think we've got essentially a one-to-one correlation between the multiple sclerosis patients who are being diagnosed with something as solid as finding ventricular plaques from MRIs and the culturing technique. But something odd that does again fit into the notion of how I see it as dysgenesis is that we can also find the same organism taking place in other people besides MS patients, people who don't necessarily in the coming months or years go on to develop MS. And we do know that there is a genetic predisposition for multiple sclerosis, and we also know that there's a particular, it seems to affect more women than it does men, and it seems to affect people from certain regions more likely than others, irrespective of any particular ethnic heritage. So there's definitely other factors involved in it. But the treatment program, we have done some innovative work in giving people with multiple sclerosis antibiotics. And in many cases, when you're dealing with some of these cell wall deficients, you have to use long-term antibiotics. 10 days of antibiotics doesn't begin to scratch the surface. So in many cases, we're using 4 and 6 months worth of antibiotics. Now, before the sensitivity testing was done, we found that what worked most often was doxycycline. And as a matter of fact, there are clinical studies outside the work that Dr. Mattman and I have been doing where minocycline, another type of antibiotic, is being used in treatment of multiple sclerosis. The people who are doing this are doing it sort of empirically, where they don't necessarily believe there's a bacteriologic etiology to MS, but this is just an observation that when people who had MS were taking antibiotics, there was significant improvement taking place. There's a lot further that one can go with this type of thing, but unfortunately when you contact the multiple sclerosis foundations, they basically look at what you're talking about and say, well, we've been there, we've done that, we funded that type of work, it didn't go anywhere, what else have you got for me? And I also have taken on a rather cynical approach to many of the disease-oriented foundations. They would seem to have a goal in perpetuating the disease in order to perpetuate their foundation. And much of the contributions that come in go towards executive salaries first, and then funding research that seems to come around. And what they like to be able to do is to have some type of results that they can show prior to the next funding drive. And they seem very hesitant in funding sweeping type of research. They're more likely to fund incremental research, some new combination, new ratios of the drugs that are already in use that yield 1/10 of 1% improvement. So I've become rather cynical with them. I think that their nightmares would be that some condition were to come along that would eradicate the disease on which their foundation is based, and they'd all have to go out and get honest work. Now, there's many different aspects of cell wall deficiency being linked with these autoimmune diseases, and they all seem to fit into this dream that I had. Chris, just to help people make notes, could you turn on the overhead? Thank you. One of the projects that's Dr. Mattman has had a hand in the past was in terms of rheumatoid arthritis. And certainly if you know anybody who's dealing with rheumatoid arthritis, it's no small problem. And a fellow by the name of Warren in the late 60s and early 70s found that there was a virus that infected the synovial cells and was responsible for a swelling and joint inflammation. Now, there was a subsequent work by a fellow by the name of Godziski who found that a different type of virus was also capable of doing this. He described it as a heat-resistant RNA virus. Now, these two viral infections seem to do nothing more than sort of set up the joints for a more persistent destructive process, and there can be several different types of bacteria that are involved with this. The one that has been best characterized, and this was a project that Dr. Mattman worked on, was a cell wall deficient form of Propionibacterium acne. Now, Propionibacterium acne is a rather common organism. It's found on the skin. It's responsible for a very serious medical condition called zits. And it's also very heavily implicated in rosacea. Metronidazole works well on rosacea in terms of a treatment. It doesn't provide much of a resolution of it. Metronidazole is pretty nasty, powerful stuff that works on a broad range of things. Now, the observations that were made many years ago by Roger Wayburn Mason were that there was some type of microorganism involved in rheumatoid arthritis, but he misidentified it, not as a serious amount, not as a major thrust of his work, but he misidentified it as an amoeba. And you'll still find references occasionally to amoeba as being a responsible agent for rheumatoid arthritis. That work has been largely relegated right now, and it's been shown that it's really a bacteria in a cell wall deficient state that is showing up in a form that could be recognized as an amoeba in a different type of body structure. One organization, the Rheumatoid Arthritis Foundation, is a little different than most of the other foundations, and they had originally begun funding much work on an amoebic basis for rheumatoid arthritis, and they have switched their gears and actually have worked up a pretty effective program for dealing with multiple sclerosis, or excuse me, rheumatoid arthritis. The organization has been run by Perry Chapdelaine, himself a rheumatoid patient, and they have a program that actually does a pretty good job in causing remission and reversal of much of rheumatoid arthritis. Now, rather than focusing on one particular bacteria, the work that Mattman did show that Propionibacterium acne was implicated, but there's also evidence that a variety of different staph and strep and even mycoplasma can be involved in rheumatoid arthritis as well. So rather than focus on one particular type of microorganism, I think we have to focus on a mechanism for cell wall deficients that are taking advantage of a damaged environment, that is these, the weakened synovial tissue from a previous viral infection. So rheumatoid arthritis, in some ways, we're looking at a co-infection. First, the damage to the joint set up by the virus, and then a longer term, and what's really responsible for the destructive effects, by a cell wall deficient bacteria. Now, sarcoidosis is another autoimmune disease, and if you read the literature on it, it seems pretty hopeless indeed. But there's several different lines of research that have implicated Mycoplasma tuberculosa as being a very important etiologic agent. Another condition that deserves a good deal of attention is Crohn's disease. Here I would refer to some of the review articles as well as original work done by Rod Cialdini. If you've known much about Crohn's disease or ulcerative colitis, it's a very desperate condition and frequently leading to multiple surgeries involving removal of strictured sections of gut and a great deal of pain and discomfort for those that are involved. It's a very frustrating condition because it tends to hit people who are in their prime of life, much as multiple sclerosis does. And quite obviously throwing steroids at it is nothing more than palliative. It works for a while and you can basically make your appointment for the next round of surgery. Rod Cialdini has done some superb work in this type of thing and has shown that a Mycobacterium paratuberculosis as a spheroplast, in other words a cell wall deficient but as a spheroplast, is highly associated with this. Moreover, Rod Cialdini has an antibiotic program involving streptomycin and rifabutin, by which he's getting some excellent results in Crohn's disease patients. Now, there's some conditions that are not clearly seen as being autoimmune, but they seem to involve cell wall deficiency as well, perhaps on a more acute basis than something like rheumatoid arthritis or multiple sclerosis. And those are strokes and heart attacks. These are not immediately seen as being linked with types of infections, and it wasn't until a fellow by the name of Altemeyer did some work where he had done something original. He had taken the thrombotic or the thromboemboli directly from surgery from people who've had strokes or heart attacks and began to culture it for microorganisms that we had much progress in this. And he was able to find cell wall deficient organisms in 50 out of 50 of the thromboemboli that he cultured. These same people had negative blood cultures by typical methods. He also noticed that a common type of oral contraceptive, Enovid, which is full of synthetic estrogens, was a profound growth factor for cell wall deficient bacteria. And it may well be that the higher incidence of thrombotic disease in women taking birth controls is related to this kind of growth phenomenon. Now, Altemeyer also found that a certain Bacteroides species produces an enzyme called heparinase, which is certainly going to increase the incidence of blood clotting as well. Now, the organism that seems to be most linked with heart attacks and strokes is Chlamydia pneumoniae. And this organism produces a very powerful hemagglutinin that is showing up very frequently in the blood of people who have had strokes or heart attacks in some very high titers. Chlamydia pneumoniae can actually be isolated from the coronary artery thrombi and from the plaques. Now, a contagious nature to strokes and heart attacks is something that is not very obvious. One of the things that Dr. Mattman passes out as advice is if a friend of yours has a stroke or a heart attack, call them on the phone, send them flowers, but don't go to visit because you may be exposed to Chlamydia pneumoniae this way by visiting somebody. And the latency period from the time that you yourself, especially if this is a contemporary of yours and probably subject to the same kind of predisposition through damaged blood vessels, develops an MI is about 4 to 6 months. Now, there's a lot of very talented people who've been working in the notion of cell wall efficient organisms. And one who's pretty well authored is a fellow named Jerry Domé from Tulane University. His particular interest is in chronic glomerulonephritis. And if you know much about this particular condition, you know just how desperate it is. Jerry Domé has been able to show that in just about every instance he's finding cell wall deficient organisms, and very commonly he's finding a cell wall deficient beta hemolytic strep as being the etiologic organism for chronic glomerulonephritis. Now, something else that's worth mentioning here is interstitial cystitis. This is unfortunately a pretty common condition affecting middle-aged women particularly, or younger women. And the urologists know that by throwing antibiotics at it, you can often cause a relief of symptoms for a while, although they would be sure to tell you that they don't believe this is caused by any type of bacteria. Routine techniques are commonly showing negative blood cultures as well as urine cultures. But a more careful type of culturing shows a gram-negative organism very frequently. Cell wall deficient forms of Borrelia, Candida, and Mycoplasma are very commonly seen in this as well. Now, the implications of cell wall deficiency and their association with some of these chronic degenerating diseases is very compelling. And right now, I don't believe that there's any condition that you would describe as being autoimmune that really fits the original definition of that, where the body's immune system simply does something silly and goes nuts and begins to attack the body. The body has more wisdom than that type of thing. And Dr. Mattman is doing some work with ALS, which is Lou Gehrig's disease, and she's finding cell wall deficient organisms linked with that. And I think if you have any other particular types of autoimmune diseases that you're familiar with, if those were to be studied in enough detail, you'd find that there's some type of microorganism linked to this. Now, much of this has to do with a different way in which cell wall deficient bacteria infect the body than conventional bacteria. Conventional bacteria are largely confined to being extracellular, and they take on a whole different characteristic when it becomes a cellulitis, when these organisms actually begin to invade the body's cells as in their native classic wild type as non-cell wall deficients. The picture is very different though for cell wall deficient organisms. These are very frequently intracellular infections from the very beginning. And this means that they have largely evaded the immune system, and they're able to carry on a much more intimate level of pathogenicity with the body and the cells directly than would an extracellular type of an infection. And the implications of this are very profound. One of the areas that I'm going to be talking about later today is a real change in thinking and bringing us back to sort of where we began in all this, where we began to study bacteria in its relationship with such diseases as cancer. The area I want to get into next is we're going to leave some of the autoimmune diseases behind, and I'd like to talk for a while about the chronic candidiasis syndrome. Obviously not a syndrome that's so desperate as heart attacks or strokes or rheumatoid arthritis, but one that I have a good deal of personal knowledge with, because this is the result of some work I did originally. The chronic candidiasis syndrome has been seen as being very much a disease of the new era. It may well be that this is something that's been going on for a long time, but it has not been really seen as and isolated until Dr. Orrin Truss described it as a syndrome back in the late 70s. And I think that still his book, The Missing Diagnosis, is the best book on the topic. There's other books that have been written, in some cases almost in coloring book form, or other books that have been written on the syndrome that were written just so that one could have written a book. But the chronic candidiasis syndrome seems to fit very well into what I call Mattman's axiom, and that is that anytime you find a significant internal infection taking place, you're going to find the corresponding organism as a cell wall deficient occurring quite systemically. The cases that I got involved with ever so long ago were that the chronic candidiasis syndrome was not something that was being very well characterized. It was sort of a collection of clinical symptoms. There was no real solid lab evidence that this type of thing was going on at all. And many conventional infectious disease specialists or microbiologists weren't taking this syndrome too seriously because from their perspective, who didn't have some level of problem from Candida albicans? It was something that everybody had anyway. But clearly something is different in the chronic candidiasis syndrome. And the disease very much focuses, or I'll call it a disorder rather than a disease in the more conventional sense. In the more specific sense, a disease is anything where something is not working right, as a dis-ease. But the syndrome very much seems to center on the gastrointestinal system, and probably involves a overgrowth, at least through the colon, as well as probably occurring much more systemically. Now, if there is an overgrowth taking place either in the colon or, in the case of the female of the species, vaginally, it would make very good sense that we would be able to find trace amounts of this occurring in circulating blood. I was doing routine blood analyses on patients who were coming to me who were diagnosed with the chronic candidiasis syndrome, and I saw any number of changes taking place in their blood, among which were things that looked to me awfully fungal. Now, little did I know at that time that conventional wisdom said, no, you cannot possibly have fungus in the blood. This would only be something occurring when the person's immune system was in desperately poor order, and it would be a sign that their immune system had basically collapsed, and this person's prognosis could probably be measured in a matter of hours or days. That kind of belief, of course, is based on dealing with Candida in its conventional native wild type of condition. In other words, with its cell wall. And as I've worked in this field, I've been accused of inventing the term cell wall deficient fungi, and that certainly isn't the case. Cell wall deficient fungi have been known and characterized for many years before I ever got in the field. But basically what I did is make a number of observations of things that looked awfully fungal taking place in a person's blood, and talked to a few people at meetings who told me that I must be in error because this couldn't possibly be. But not knowing much better, I persisted in this and took some of my observations to my mentor in microbiology, which is Lyda Mattman. And unlike most people who would have been subject to the prejudices of the time, would have said, well, no, I'm afraid this can't be, just made some funny observations here. She actually indulged me in this notion and began to use some different means of testing. One of the original things that we did, and one of the things that's available to any of you as well who have a microscope, is to do some fluorescent type of staining. One of the things that clearly defines a microorganism from some piece of tissue debris or some type of fragment of garbage is the presence of nucleic acids. And a very inexpensive stain that one can use is called acridine orange. Acridine orange specifically binds to DNA and RNA, and really very little else. And what we began to do is to take patient blood specimens from these chronic candidiasis patients and stain them with acridine orange, and certainly the nuclei of the white blood cells should show up. But there should be none of this taking place in platelets or red blood cells. And if we had something that looked morphologically like some type of an organism and it showed signs of DNA, that has to be seen as a piece of evidence. Now, there are other types of nucleic acid stains that we used as well. The acridine orange works very well on DNA or RNA, but we also used one called ethidium bromide, which works in a rather similar type of way. It only specifically binds to DNA. And once again, we could distinguish the DNA of the nuclei of the white blood cells. And then there were these other things that looked morphologically fungal that were showing up with nucleic acids in there indisputably as well. So that was a second leg in all of this. The third thing is that in Mattman's lab many years earlier, and they had developed a technique of autofluorescence of fungi. And if any of you have walked in the woods during the spring, many times you've seen fungi glowing. Fungi routinely have a fluorescence about them. They will glow from previous exposure to ultraviolet light. This is the basis also of the woods lamp. If you're looking for skin fungal infections, if you darken the room and shine an ultraviolet light, many times you'll see the fungal infections of the skin just glowing away at you. But Mattman had a graduate student who had developed this technique a bit further for cell wall deficient candida in particular. And as we subjected stains or preps that we made with no staining or any other type of alteration to ultraviolet light, we could see this kind of an autofluorescence taking place. That was another piece of evidence. As you looked at these things, you could watch them doing fungal-like things. They would bud, they would form into long mycelia. You would see them, well, one of the things I developed along the way, largely out of a bit of sloppiness, was what I call Phil's quick and dirty culture technique, which is when you're too tired by the end of the day to clean up your microscope, you leave the specimen on there and come back and look at it the next morning, when perhaps you're feeling a little more energized and more likely to clean up your microscope. And when you leave a specimen of blood on from somebody who had the chronic candidiasis syndrome, you'd be amazed what bestial dragons you might find in the morning. You find these very long mycelia that have grown out. And these could be just of an amazing pervasive nature. It's kind of interesting that I find this now heralded as a diagnostic technique, Phil's quick and dirty culture technique. It wasn't quite so intended at the time. The next step in identifying this further and putting more evidence on it was to work with some of the monoclonal fluorescent antibodies. Now, fluorescent antibody has a molecule, fluorescein, that glows a nice green apple color under certain wavelengths of ultraviolet light. And when you can attach that to a monoclonal antibody that is very specific for certain antigens found only on the surface of Candida albicans, it allows you to selectively characterize Candida albicans. And this technique is considered sufficient for diagnosis by many standards. We didn't develop this technique, but what we did was to buy this expensive antibody that only worked, as a matter of fact, on certain strains of Candida albicans. And we subjected that to specimens that we made, and lo and behold, we got some specific binding taking place. Now, at this point, I had discovered just how extensively Dr. Mattman had been humoring me, because now she became a believer as well. And that we were finding Candida taking place. And Dr. Mattman has extensive culturing technique in dealing with cell wall deficient organisms, and particularly with Candida albicans being among them. And we've been able to do culturing of the blood of the chronic candidiasis patients, and have been able to successfully grow Candida albicans in a reverted apparent form, easily characterized as being Candida, in about 500 out of about 700 cases that we worked with. That's pretty good. Now, the chronic candidiasis syndrome is not a life-threatening condition as it's being defined. This is not like the type of overwhelming candidiasis that takes place when a person's immune system has failed. As I attempted to put this type of material together into an article, I ran into a great deal of conventional wisdom that said, well, just no matter how much work I had done in this type of thing, I must have done something wrong because this couldn't possibly be taking place. And the reviewers would send back notes, well, you know, how many controls did you run? And if I would say I ran 300 controls, they would say, you would have found something different if you'd run 500 controls. And they'd ask me for the source of the antibody, and the antibody I was getting was standard reagent. I think it was from DIFCO. And they said, well, you know, if you had tried several different lots, you would have seen something different. Really, what this really demonstrated was that in many cases, science is anything but very objective. When you try to get novel ideas past reviewers, you can be running into walls very frequently. And this is something that Dr. Mattman, and I would imagine if I could speak for you, Dr. Whitaker, you've run into quite a few of these walls through time as well. And that's just where she is these days in some of her brilliant work on Lyme's disease. Again, I have to give credit back to Borgdorf for some of the splendid work that he did in characterizing Lyme's disease as being the result of a spirochetal bacteria. Had it not been for his excellent work taking place when it had, we'd be looking at this probably as some other obscure autoimmune disease with no other treatment for it than antipsychotic drugs and steroids. But it is very difficult to provide, it is impossible to provide enough evidence that will suffice as proof for a mind that is thoroughly closed. And you find that these closed minds are often between the ears of people who are considered the arbiters of their particular field. It makes for a very frustrating type of path in science, and it's something that really can't be tolerated, but it's something that we have to deal with anyway. Now, where we're going with all this is that in the next segment of the talk, I'm going to be getting into the holiest of holies, when we're going to be talking about more speculative type of things. We're going to move past the autoimmune diseases, and I'm going to be talking about the role for viruses and cell wall deficient bacteria and fungi in cancer. And also at that point, I'd like to be able to show you slides as to how some of this stuff appears in the blood. Perhaps we can get a VCR in here so I can show you some tape as well, because I've got some really interesting tapes. I've had the good fortune of having many eureka moments, and many times these eureka moments are followed immediately by wanting to whap yourself up the side of the head for having been so dumb up to that point. There are things that you see taking place in the real world of a patient's blood that you have no idea as to what they are. And somewhere off in a corner of your mind, you put these to the X file. And you may see these things, at least they may pass in front of your eyes, but certainly while you're not feeling very comfortable with these things as to what they really are, or if they have any importance at all, you tend to ignore them. And then something comes along that rattles your reality, and you have one of those eureka moments. So that's what this is. And then, whap, how come I didn't figure this out so much earlier? It was patently obvious. in that regard, the videotape, I've got some great segments of, and you do have to look closely at some of this stuff, of mycoplasma. In communications that I've had with Harold Clark, who I have to look at as being pretty expert in the field of mycoplasma, I find that they have some very distinct stages in their morphology. And I've seen these types of things floating around in patients' blood and had no clue as to what they were until the communication with Dr. Clark gave me that eureka moment. And working with the patient's blood allows you a very powerful perspective. And these days the patients have become my best teachers, as each of them, by their own experiences and encounters, has things that have never quite occurred before, quite in that combination of ways. And if one can simply peel the protective layers and biases off their eyes, there's a tremendous amount of information taking place in a drop of blood. And I feel very privileged intellectually to have worked with the patients that I have over the many years, because they've allowed me the kind of perspective that I have, the understanding that has come from the study of their conditions. Now, that's a different type of statement than what you might get from a physician, and therein lies the difference between a medical scientist and a physician. Practitioners, their goal is always the patient. It's the patient first and the patient last, and you gauge exactly what you're doing by the patient. But I guess I wasn't cut out to be much of a physician, because I work more towards mechanisms. I try for the understanding as to what is going on. So if I do a pretty good job of this type of thing, I have the opportunity of passing it on to practitioners such as yourself, who can then take this and do something with it. And I encourage you to rail against conventionality, to have radical thoughts, to not accept the walls that are put up where something is unknown, and a belief that beyond this lies dragons, such as the old maps that would tell us that we couldn't sail past these points because we would fall off the world. You may find things that you weren't necessarily ready to deal with, and you may come to unpopular conclusions, but this is really the only way that one uncovers truth. And it's that type of truth that gives you the power to help people. And I think ultimately that's what medicine has to be all about. So what I'd like to do in the last few minutes is to field some questions about this. If I've skipped over what may be some of your favorite or particularly applied autoimmune diseases, I'd like to field some of those questions. If I can't help directly, I can at least probably put you in touch with a reference. Brenny, dear.
Is there any specific disease process associated with Klebsiella, like you have listed here, Klebsiella?
Well, the short answer to that one is not necessarily, but the bigger question, or the bigger answer to that one, is that while I've made it also neat here, where I've tried to link up a particular condition with a particular microorganism, the real world is not that neat. To where there may be a number of different types of microorganisms that are able to produce a distinct disease state, provided that they find the host in a vulnerable position, either by a certain type of tissue damage, such as this one virus that goes through and damages the synovial cells in RA patients, or a genetic predisposition for somebody with multiple sclerosis. So this kind of linearity really doesn't exist, and certainly Klebsiella is a condition, is a critter with a lot of potential to it. But I have to do some digging to find out more specifically what it may be associated with. So that was a dodge of perhaps a better answer. Okay, let's work our way back. Oh yeah. Well, particularly the synthetic estrogens, and well, What this fellow Altemeyer found was that he worked particularly with the drug Enobid, which contains certain proprietary synthetic, we'll call them pseudoestrogens. And he found that those had a general growth promoting effect for cell wall deficient organisms. Now, how pervasive that is to other synthetic estrogens, that's speculative at this point. That wasn't part of his work. The possible link between, well, there is a link between taking oral contraceptives and these mysterious thrombi showing up in women who have no other predisposing factors for them. It's appealing to think that there's a more general mechanism taking place here, but that's still speculative at this point. Okay, working our way back, please.
Do you have any comment on Tourette's syndrome, by chance, with any of these cell wall deficient?
Well, that is something that I don't think that that would be involved in the neuropathic stealth viruses with which Dr. Martin has been working. I don't think that I've seen that listed in his work, in his publications. That might be a question you could ask him directly. And what I will do when I come back in a later segment is I'll have his address and phone number so you could ask him directly at that. I haven't got a good answer. Okay, please, sir.
Just a statement about the bugs like chlamydia and stuff in coronary artery disease and vulnerable plaque, that oxidative therapies have been very helpful in our hands. Peroxides and IV ozones and major chemotherapy and UVB really stimulated the immune system. We'll get an aggravation, for example, of angina for a day or two, then people with chronic angina patients, this is totally gone, totally leaves, and wasn't touched by a lot of chelation. But oxidative stuff was very helpful.
Please continue.
And a question, those of us that do a lot of dark field microscopy find the slide under the scope the next morning, we were seeing all these same critters floating around, and with all the nice long fungal tubes and all the guys waving at you in the morning. And certainly Enderlein has a delightful nomenclature that he's put together over all these years about the lore of Mucor racemosus. And but do you think this is mycoplasma and fungus and candida and other guys and not just Mucor?
Your question comes in many parts, and there's a number of parts that I'd be very eager to address. The first one is, while I'm trying very hard not to pick on Enderlein, because he certainly made observations, he made a lot of observations, he was almost obsessed with the observations. But what he did was to see something happening and chart it very carefully and presume that's necessarily how it had to be. And one of the fallacies of the Enderleinism is this notion of a distinct sequence in the growth cycle. That when you've got an endobion, the next step has to be something else. And truthfully, what he's doing is making the situation more ordered, and he's coming up with these artificial names than what it really is in the world. Truth is that he may have made very careful observations in cultures and seen a particular life cycle taking place one way, but the truth is that in another phase of the moon, after a thundering bowel movement on the part of the patient, the thing may have changed entirely. And these organisms don't necessarily follow a particular life cycle in an ordered form. Now, certain types of conditions in the patient may be predisposing toward a particular pattern. If the patient is becoming more alkaline, for instance, or that there's more or less available glucose or some other type of nutrient that the organism likes, it may tend to lead them towards different types of body structures. But there's a great number of variables in this, and whereas his diagrams show this very neat type of life cycle going from one step to another, if you follow enough of these, what you find is that the pattern is much more varied. These can jump from many different stages to another, bypassing ones that he thought that had to be there. This may have been as he was attempting to find order, more order than existed among this type of process. Now, on to another aspect of your question, and maybe you meant that more of as a statement, but it's something I have to address as well. I have seen a number of patients who've been through various forms of oxidative therapies, and I have had any number of conversations with Dr. Farr on the topic, who was sort of the guru of this. And I went so far as to look up the vast majority of references, particularly where it related to vascular disease. And my observations and my reading of the references that he used didn't follow at all what his observations and his conclusions were. I have found that people who are using hydrogen peroxide with the notion of dealing with vascular disease are more likely to be aggravating the problem. What we've learned about atherosclerotic plaque is, as a single statement, the reason that it's there is it's a response to an injury. And the most common nature of that injury is free radicals and oxidative stress. And I find it absolutely amazing that a practitioner who would have been schooled in chemistry since the 60s, where free radicals and the effects of oxidative stress have been pretty carefully delineated, could talk about the importance of antioxidants and how they would protect cells in one sense, and then in the other sense, in the next sentence, talk about the value of giving somebody hydrogen peroxide infusions with the notion of healing their arteries. From the perspective that I've had of dealing with patients who've had vascular disease, I have seen short-term effects where people have had literally a thrombotic crisis, and there's reason to believe that peroxide and other forms of oxygen radicals can initiate blood clotting, either through fibrin formation or platelets, bypassing the normal mechanisms of thrombin activation or normal mechanisms of platelet activation. I've had two friends die as a result of taking infusions of peroxide. One of them with the IV still in his arm, and the other one within 24 hours. I've had a chance to study these patients through ultrasounds and through thermology, where I can actually see the delivery of blood to the tissue. In the patients that I've seen take the peroxide infusions, I've seen some consistent results of a much worsening state of their arteries. The arteries are becoming much more damaged as a result of the oxygen-free radicals. Now, the picture changes entirely if we're talking about the non-parental use of peroxides or ozone in cleaning out things like cavitations. If we're going after some of the osteos and we're using it in a localized way, these oxygen radicals are very effective means of killing microorganisms. And if we're doing so on a local basis, clearly, where we have different types of things that are available to us to attempt to kill the critters locally, we're going to have less toxic byproducts from things like peroxide or ozone than we would using a lot of other types of materials. So I think that there's a great benefit in that type of application. But I really don't like either the notion of intravenous or oral administration, or for that matter, the colonic administration of peroxide or ozone. I've seen a lot of bad effects of that type of thing. Maybe that isn't what you wanted to hear, but that's my honest observation.
I haven't noticed a lot of that same stuff, but I think it is really good as an anti-bug, inducing the immune system and inducing red blood cell ability to get rid of oxygen into the capillaries. I think it has, at least in the short term, And I couldn't agree with you more about injecting cavitations with those. Also
Okay.
great for spider bites. It totally gets rid of brown recluse spider bite venom, by the way.
Okay,
What you have
now,
to do is numb up the bite with a little bit of procaine and inject the gas right underneath the spider bites. And a total of 2 or 3 injections is totally gone.
Most of the positive features that are seen about the intravenous peroxide or ozone when done intravenous mainly comes as it evokes a response from the host. There's a very powerful detoxifying response that takes place, and the body will produce much greater levels of antioxidants as a result. So what you're really getting in terms of, I think, the best response from this, or the best results, is a host response to produce more antioxidants and do a general detox. And what I'd suggest that you do is to look into some of the homeopathic agents that can do the exact same thing. There are oxidative catalysts that are available with homeopathic doses. In some cases, really very powerful oxidizers that are many orders of magnitude more powerful than something like peroxide that are administered homeopathically in the neighborhood of 40x or up to 1m type of potencies. And these can do very powerful things to evoke a detoxifying and a antioxidant type of response. And in the meantime, because you're giving it homeopathically, you're not exposing that person to the noxious agent so directly. Okay, that was a... Well, in that regard, I'd have to turn you on to an old-time homeopath who did his work at my alma mater, which is Wayne State University, and his name was Wilhelm Koch, or Koch as we anglicize it. And Koch was a professor of physiology and pathology back into the 40s and 50s. And he was able to function in this bastion of orthodoxy and still hang on to his homeopathic roots. And he developed a few materials in this regard. One of them was referred to as glyoxylide, and another one that he worked with was PBQ, parabenzoquinone. And he worked with these in some very potent dilutions and was able to achieve this kind of an antioxidative response. Koch's original application for this was in cancer therapy. Truth is that Koch was a lousy scientist in terms of keeping track of the results on his patients. He did nothing in terms of statistical studies and didn't do much to gather results. It was largely anecdotal. It may well be this has only a very limited application in terms of cancer itself, but as people have continued to work with these materials, and particularly the glyoxylide material, it's an extremely effective material in stimulating antiviral activity. It's one of the more effective things that you would find in dealing with some of the chronic herpes viruses, herpes simplex, cytomegalovirus, Epstein-Barr virus, human herpes 6, 7, and 8, all seem to be very directly targeted by this homeopathic. And it's still available, but through not very obvious sources.
One more question.
Heal has it. The experiences I've had have not been with the Heal product, so I couldn't tell you whether theirs is a particularly good one or not. In some cases, it's being produced by individual practices and using it that way. Okay, please, sir.
Is mercury in any way associated with creating a terrain aspect that allows for the cell-deficient wall organism to...
Oh, absolutely yes. Absolutely yes. One of the things that an old friend of mine was working on when he was affiliated with Hal Huggins was that mercury seems to directly potentiate some of these organisms to become cell wall deficient and to take on a whole different pathogenic character. It's curious that particularly the spirochetal organisms, once upon a time were treated with mercury. One of the early forms of treatment of syphilis was by taking mercury. And the old adage was an hour with Venus and the rest of your life with Mercury. This very much fits into it. Whether the mercury is directly potentiating the organism or altering the terrain, there is definitely an association taking place. And this friend of mine, Walt Clifford, doing some work with Hal Huggins years ago, had done some specific work in this, and I'd reference you to his type of stuff.
Why don't you ask a couple of questions this afternoon? Now, starting at 1:30, we'll be back and have pictures. Those of you who like textbooks with pictures, come back. All right?
Yeah, we'll try to make this stuff all the more graphic. And I'm going to show you, all right, it hasn't been too graphic so far. I'm going to show you, especially you very visual people, what some of the infected lymphocytes look like from cytomegalovirus and Epstein-Barr virus, and show you what some of the bacterial critters look like and what some of the fungal critters look like as we can see it in our clinical patients. All right, I thank you very much.
Here we go. Hold on. Doctors and spouses, they want lunch down the hall this way. I just want to say a few minutes, okay? So nobody please leave.
Thank you for giving me the opportunity to speak for just a few minutes. My name is Gisela Traves. I'm with the company here, Target Your Health, and I hope all of you will have an opportunity to stop by there. Our claim to claim is 3 different products which have been on the market, on the German market for the past at least 10 years. We have clinical documentation on most of our products, and we also have a patent on it. One of the products is the heavy metal test. It is a chemical, non-electrical, scientific documented test which allows you to check your clients, your patients, or yourself for the content of heavy metals in your urine or any liquid